Yes, thank you, David. So, you all know that the European Society of Cardiology published its guidelines in September 2015, and these guidelines were endorsed by the European Association for Cardiac Thoracic Surgery and the Nuclear Medicine Association, but not the microbiology, European Association of Microbiology. As you see on these slides, the recommendations are classified in 3 classes. The first one, the action is recommended. The class 2 is subdivided in 2 subclasses. 2A, the action should be considered, and 2B, the action may be considered. And the class 3 is the action is not recommended. Sorry. Let's start with prevention. You all have seen this paper published in the Lancet in April 2015 from Dyer and collaborators, showing an increase in the rate, in the incidence of IE in UK since the abandonment of antibiotic prophylaxis. They have shown a marked reduction of antibiotic prophylaxis since 2008, and concomitantly, they reported an increase in the incidence of IE, both in prosthetic valve patients in red and in native valve patients in blue. And they showed that this abandonment of antibiotic prophylaxis was responsible for 35 additional IE cases per month. Despite these results, the ESC 2015 guidelines did not modify their recommendation to prevent IE in these patients. As you can see, only patients at highest risk of IE must have antibiotic prophylaxis. It's a 2A recommendation, and only for dental procedures which are responsible to manipulation of the gingival tissue or the periapical region. And for these patients, the antibiotics are still the same: ampicillin 2 grams and clindamycin in case of allergy. These patients must have strict dental hygiene and cutaneous hygiene, no self-medication in case of fever, and we must limit the use of infusion catheters. And it is also recommended, it's a class 1 recommendation, to use perioperative prophylaxis in case of pacemaker or deaf implantation, and to screen for nasal carriage of Staph aureus before elective cardiac surgery. So to conclude the prevention chapter of this recommendation, there is no modification, a limited indication for antibiotic prophylaxis, only in patients at highest risk of IE and only for dental procedures, and general hygiene is very important, and pre-operative screening for Staph aureus must be performed, such as antibiotic prophylaxis prior to pacemaker and deaf implementation. In these guidelines, they have created the endocarditis reference centers. There is data in the literature reporting a worse prognosis of IE patients who are not referred to reference centers. In these centers, the patients must have immediate access to nuclear imaging, cardiac surgery, and specialists in IE care. This is the endocarditis team, which must taking care of patients with complicated IE, and as you can see on this slide, these patients must be referred to these reference centers, and in patients with non-complicated IE, there must be regular communication with the reference center to take care of the patients. The endocarditis team must have regular meetings and choose the type and the duration of antibiotics, the surgery indications, and participate in registry, and be organized to follow patients after discharge during approximately 1 year. Concerning diagnosis of IE, it's always based on echocardiography and identification of the microorganisms through blood culture. The guideline is very clear concerning the indication of echocardiography, especially TOE, which must be performed in quite old patients. Concerning blood culture, as you can see, in case of negative blood culture and negative serologies, you must perform blood PCR to detect microorganisms. An important point in this recommendation is the application of the Duke classification in the diagnosis process of IE. With the results of the blood culture and the echocardiography, you apply the modified Duke criteria, and in patients who are possible or rejected IE cases but with high suspicion of IE, the guidelines recommend to perform second-line imaging techniques, including cerebral CT scan or MRI and total body scan, and to look for asymptomatic peripheral IE manifestation of IE, and to perform cardiac CT scan, and in prosthetic valve patients, TEP CT and leukocytes labeled SPECS PT to establish valvular involvement, and to reapply the classification, the European 2015 modified classification, which include, as you can see, as a major Duke criteria, the abnormal activity around a prosthetic valve or the presence of paravalvular lesion by cardiac, evidenced by cardiac CT. In this, as you can see, the American recommendation said that more study is needed to define the utility of TEP CT scan in the diagnosis and management of IE. In this European modified diagnostic criteria, as you can see, the asymptomatic detection of lesion by systematic imaging is a minor criterion. When we move to antimicrobial therapy, I will be very brief because there is another talk in this session. The general consideration is concern the duration of antibiotic, which must be 2 to 6 weeks in native valve IE and above 6 weeks in prosthetic valve patients. Concerning the antibiotic choice, as you can see, aminoglycosides are no longer recommended in native valve Staph aureus IE, and aminoglycosides are now administered once daily in all patients. Rifampin is only used or recommended for prosthetic valve IE and is recommended to be initiated 3 to 5 days after the initiation of other antibiotics once the bacteremia has been cleared to avoid the selection of resistance Staph aureus. And concerning daptomycin, the dosage is above 10 milligrams per kilogram once daily, and always associated with another antibiotics. As you can see, there was no consensus concerning the treatment of staphylococcal IE, and the empirical treatment is, as you can see, debated. In these guidelines, as you can see, the amoxicillin clavulanic acid combination is no longer recommended for the initial empirical treatment of IE. The combination is the ampicillin, oxacillin, and gentamicin combination. Concerning valvular surgery, the indications are not modified for the heart failure indications and for the uncontrolled infection indication. There are differences concerning the prevention of embolism. You can see the 2009 guidelines here, and bottom the 2015 guidelines. As you can see, there are two additional indications for surgery to prevent embolism, which are both of them class 2A, so should be considered. It's based on the size of the vegetation, and surgery, cardiac surgery, should be considered in vegetation size above 10 millimeters, and in vegetation above 30 millimeters with no other conditions. When a patient has a cardiac indication, this indication is contraindicated in case of intracranial hemorrhage, severe comorbidities, and stroke with severe damage. So to conclude, there is no modification of antibiotic prophylaxis strategy. The guidelines recommend the creation of eye reference centers with an endocarditis team. There is a major place of new imaging techniques in doubtful IE situation. The guidelines propose a modification of the Duke classification. Aminoglycosides are no longer recommended in native Staph aureus IE, and emboli prevention is now a recommendation for cardiac surgery independently of other indications based on vegetation size. Thank you very much.
Thank you, Xavier. Is there any question from the audience? Samuel?
Thank you for the presentation, but I want to know your mind about dental implants in the group of patients high risk.
Yes, in these guidelines, dental implants are not contraindicated in all patients.
Yes,
No longer. It's no longer contraindicated.
Antibiotic prophylaxis is the same?
For these patients, it's, let me think of it. There is a prophylaxis at the time of the implantation, but not thereafter.
So if I'm correct, the dental implant is not anymore absolute contraindication in patients, let's say, with valvular heart disease. Does it apply also for patients that are high risk? I think these patients are still contraindicated for implants.
It depends. In the European guidelines, implants are not contraindicated. It's contraindicated in France, but not in the European guidelines.
What you do is well.
Do you follow the patient with a PET CT. If you do a PET CT to have a diagnosis and then treat the patient, if the patient reacts, okay, it doesn't react, there's still fever, you're not sure of there is any indication to repeat the examination.
It is a topic of François Rouzet, which has talked about it. Yes, it depends. In some cases, yes, we are doing again the TET CT scan when the response is not correct. Yes.
Thank you very much for this slide talk. Do you have, did you change your guidelines for the timing of surgery, which is one of the major issues in this topic?
No, I'm not sure that the timing has been changed. As you can see, yes. The time is still an emergency in case of heart failure, and the time is urgent, and urgent corresponds to within 7 days for other heart failure indication and control infection. So I don't think the timing has been changed.
So the recommendation has not changed about how early we should do surgery, but I guess for our institution, I think we have a little bit changed. We are quite aggressive in case of latinitis and try to do early surgery. There is very few data. The paper from the Korean group has randomized patient early surgery compared to conservative management. Number of patients is very limited, but there is some argument to perform early surgery in patients with endocardinitis. I have one question. If you have to do completely a de novo endocardinitis team, what are the specialties that are mandatory in your opinion?
This is written in the guidelines, but I think, as you can see in the guideline, it's written that the endocarditis team must include a cardiologist, imaging specialist, yes,
Maybe
that's all. Cardiac
surgeon.
surgeon, and infectious disease specialist, and what else? A neurologist, and I think it's, yes, a team which is specialized, or a doctor who are specialized in pacemaker extraction. So I think we need all these specialists in some cases to treat and cure our patients.
Very important how all these specialties all together to discuss all the case. Some are very easy, but some are very complex. You know that for every week you are leading our team in the show, and some cases are very difficult, and it's very important to have the different opinion of many specialists. Any other questions?
Okay. Thank you very much.